Hello everybody. Welcome to number 1 Doctor channel. Today video is about skin surgery, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about skin surgery. Exposure to the sun is the main cause of skin cancers. The typical victim is a fair-skinned person who does not enjoy the protection afforded by melanin. The damage is cumulative. A patient who repeatedly had sunburns with blistering as a youngster is very likely to develop cancers in later years. Basal cell carcinoma accounts for about 50 of these. 3 features are typical. It favors the upper part of the face, it has a timetable measured in years, and it does not metastasize. It kills by relentless local invasion rodent ulcer. It may look like a waxy, raised lesion, or it may be an ulcer. The former can be simply excised, for both diagnosis and treatment. The latter should be biopsied at the edge. Resection requires only a 1 mm margin all around. To assure cure and avoid unnecessary mutilation, a sophisticated method called Mohs surgery performs repeated microscopic sections as the excision is being done. Squamous cell carcinoma represents 25 of skin cancers and prefers the lower lip and the rest of the body. It has a timetable measured in months, and it can metastasize to lymph nodes. The latter may need to be sampled and, if involved, removed. Surgical margins for the primary lesion should be 0.52 cm. Radiation therapy is another treatment option. Melanoma is the most lethal of these tumors. Incidence is currently increasing from a long-quoted figure of 15 of skin cancers. It usually originates in a previously benign pigmented lesion. The mnemonic to recognize melanomas is A, B, C, D, E. They are asymmetrical A, with irregular borders B, different colors within the lesion C, and a diameter exceeding 0.5 cm D, or they have evolved D, i.e., an existing pigmented lesion has undergone a sudden change in its usual appearance. The prognosis and management of melanoma is determined by its depth of invasion. The details keep changing, but the basic idea is simple. Superficial lesions have good prognosis, deep ones do not. Melanomas less than 1 mm deep require only local excision. Deeper lesions require wide margins 2 cm and attention to lymph nodes biopsy and/or remove as needed, and those between 1 and 4 mm benefit the most from aggressive efforts. Lesions beyond 4 mm have a terrible prognosis regardless of therapy. Metastatic malignant melanoma is a bizarre, unpredictable, and fascinating disease. It goes to the usual places: lymph nodes, liver, lung, brain, and bone. But it also is the all-time champion for metastasizing to weird places. Furthermore, it has no predictable timetable. Some patients are full of metastases and dead within a few months of diagnosis and treatment. Others go 20 years or more between the original treatment and the sudden explosion of metastases. Disseminated melanoma cannot be cured. Interferon offers a modest improvement in survival time, and thus has been the standard treatment. We now favor targeted therapy, which may be better. The tumor genes are studied and the best agent chosen. These include chemotherapy dacarbazine and immunotherapy pembrolizumab. The latter is credited with dramatic improvement for former President Jimmy Carter, whose brain mets from melanoma melted away. No one claims that he was cured, though. In their own advertising, the manufacturers of pembrolizumab promise only a chance to live longer. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes, Dr. Atef Ahmed. Wishes.